The peripheral nervous system is the link between the outside world and the brain. It includes cranial and spinal nerves, as well as a number of ganglia, receptors and other types of nervous tissue. In this section, we will look at the location and function of the 12 pairs of cranial nerves that are associated with the brain. Recall that the nervous system as a whole is divided into two major parts, the central nervous system, which includes the brain and spinal cord, and the peripheral nervous system that includes every other bit of nervous tissue outside of the CNS. Use this slide to review the arrangement of the nervous system, and the relationship between the CNS and PNS. Notice that the PNS is divided into an incoming, sensory or afferent division which conducts information about certain types of stimuli from receptors to the CNS where processing takes place. It also includes the outgoing, motor or efferent division which delivers integrated commands to effectors. The motor division is subdivided into the somatic and autonomic nervous systems. The somatic division serves the voluntary muscles, whereas the autonomic nervous system innervates the viscera, glands and smooth muscle. The autonomic nervous system is subdivided into two branches that oppose each other in action, the sympathetic and the parasympathetic divisions. Before we examine the function of the cranial and spinal nerves, let's take a look at what exactly comprises a nerve. Nerves are a bundle of axons, some are myelinated and some are unmyelinated. These fibers are bundled up by connective tissue wrappings. The entire nerve is wrapped in a tough CT called the epineurium. The epineurium projects into the nerve as the perineurium, which divides the nerve fibers into discrete bundles called fascicles. The perineurium also brings with it a blood supply into the nerve. Each axon is surrounded by an endoneurium that surrounds the myelin sheath or neurolemma. Most nerves are mixed, carrying both sensory and motor fibers, as well as somatic and autonomic fibers. Ganglia are collections of neuron cell bodies associated with nerves in the PNS, somewhat analogous to the nuclei of the brain. Peripheral nerves are classified as cranial or spinal nerves depending on whether they originate from the brain or spinal cord. There are 12 pairs of cranial nerves. 10 of the 12 pairs arise from the brainstem. All pass through openings in the skull such as fissures and foramina to gain access to and from the periphery. The cranial nerves are both numbered and named. The numbering system is based on the order in which they arise from the brain, beginning from the anterior to posterior. The nerves are also named based on their primary function, such as the olfactory nerve, which conveys the sense of smell, or what they look like, such as the trigeminal, which has 3 major divisions. Most of the cranial nerves are mixed, carrying both sensory and motor fibers, however some are only sensory, and some are predominantly motor. Several carry autonomic fibers as well as somatic fibers. The olfactory nerves or cranial nerves are exclusively sensory, carrying afferent impulses for the sense of smell. The olfactory nerves arise from receptors which lie in the olfactory areas of the nasal mucosa covering the superior nasal conchae and the superior part of the nasal septum. The axons of the olfactory receptors form bundles of fibers called the filia olfactoria, which pass through the olfactory foramina in the cribriform plate of the ethmoid. As soon as they enter the skull, they synapse in the olfactory bulbs. Postsynaptic fibers from the olfactory bulbs course posteriorly as the olfactory tract to enter the primary olfactory cortex in the temporal lobe of the brain. To test cranial nerve I, the patient is presented with several odoriferous solutions that they are asked to identify. If the patient has difficulty identifying the smells presented to him, this is called anosmia. The most common cause is a cold or allergies affecting the nasal mucosa. Sometimes trauma or meningioma, typically a benign tumor of the meninges, may compress the olfactory tract. The optic nerves are also purely sensory. They arise from ganglion cell axons, third-order neurons of the retina, and carry afferent impulses for vision. The axons of the ganglion cells form the optic nerves, which enter the skull through the optic canals. From there, the left and right optic nerves partially decussate, forming the optic chiasm, and then continue on as optic tracts to the lateral geniculate of the thalamus. Some fibers pass to the superior colliculi, which coordinate the eye muscles so we can track objects. Most of the fibers pass to the primary visual cortex in the occipital lobe. The oculomotor nerve, as the name indicates, plays an important role in eye movements because it is motor to 4 out of the 6 extrinsic eye muscles. However, it does much more. The oculomotor nerves arise from the midbrain and pass through the orbit via the superior orbital fissure to the eye. Somatic motor fibers innervate the superior, medial and inferior rectus muscles and the inferior oblique muscle. CN3 also innervates the levator palpebrae superioris, which raises our upper eyelid. In addition, the oculomotor nerves carry parasympathetic fibers to the circular muscles of the iris, which cause the pupils to constrict in bright light or when focusing for near vision. Other parasympathetic fibers control the shape of the lens, which needs to change thickness in order to focus images on the retina. Some of the parasympathetic cell bodies are located in the ciliary ganglia, where they synapse before entering the eye. These images are from individuals suffering from third nerve palsy. The symptoms include double vision or diplopia and ptosis, drooping of the eyelid. Recall that cranial nerve 3 innervates the levator palpebrae superioris. The top image shows right ptosis, and superduction of the right eye is limited. This means that when the patient is asked to look up and out normal in the left eye, the affected eye cannot move normally. This individual was diagnosed with paresis, weakness of the superior branch of cranial nerve 3. In summary, signs to look for include ptosis, eye directed down and out, limited eye movements in all directions except toward the ear. Trochlear nerve, the abducens, innervates the lateral rectus, resulting in abduction of the eye. Dilated pupil and minimally reactive to light. Third nerve palsy may be caused by a compression lesion of the nerve if the pupil is involved, or a microvascular disease if the pupil still functions. The fibers forming the trochlear nerves originate from the midbrain and enter the orbit through the superior orbital fissure. It is primarily motor to the superior oblique muscle, but also carries proprioception fibers from the muscle. The superior oblique muscle depresses the eye and turns it laterally, down and out. Individuals with fourth nerve palsy often present with their head tilted toward the normal side, and the affected eye appears higher compared to the normal eye. Fourth nerve palsy results in a vertical double vision. Cranial nerve V, the trigeminal, is the largest of the cranial nerves. It arises from the pons and then forms 3 branches, the ophthalmic, maxillary and mandibular divisions. It is from these 3 divisions that the nerve gets its name. Trigeminal trigemina equals threefold. The ophthalmic division V1 is sensory, with the fibers running from the face to the pons through the superior orbital fissure. It also carries sensory fibers from the cornea, lacrimal tear gland and nasal mucosa. The maxillary division V2 is also sensory only, with its fibers running from the face to the pons through the foramen rotundum. This division also carries fibers from the lower nasal cavity and from the upper teeth. The third division is the mandibular division V3. It carries both sensory and motor fibers. The sensory fibers convey information from the lower teeth, in addition to the skin and scalp as shown. The motor division supplies the muscles of mastication and some of the muscles used in swallowing. Cranial nerve V is called the abducens because it is motor to the lateral rectus muscle of the eye, which when stimulated causes the eye to abduct as when moving the eye laterally. Motor fibers leave the pons, enter the orbit via the superior orbital fissure. Sensory fibers are mainly from proprioceptors. The lower picture is of the abnormal eye position of an individual suffering from left abducens palsy. In other words, he cannot look to the left with his left eye. The facial nerve is quite complex because it carries somatic sensory as well as taste fibers. It is motor to the muscles of facial expression, scalp and neck, and also carries parasympathetic fibers to glands. The top figure B shows the distribution of the 5 major motor and proprioceptive branches of the facial nerve. The bottom figure C demonstrates a simple way of remembering the distribution and course of the branches. The facial nerve courses from the pons, enters the temporal bone via the internal acoustic meatus, and runs within the temporal bone and through the inner ear cavity before emerging through the stylomastoid foramen. Once outside the skull, the facial nerve then courses to the lateral side of the head and face. Cranial nerve 7 carries parasympathetic fibers to various glands in the face, such as the lacrimal or tear gland, nasal and palatine glands, and the submandibular and sublingual salivary glands. It also picks up taste fibers coming from receptors located in the anterior 2/3 of the tongue. These fibers travel in the chorda tympani branch of the facial nerve. This nerve is also the one affected in Bell's palsy, unilateral paralysis of the facial muscles resulting from inflammation, infection or stroke. Note the asymmetry of the face. The affected side droops because the muscles of facial expression are essentially paralyzed. Cranial nerve 8 is called the vestibulocochlear because it has 2 major branches carrying 2 different kinds of sensory information. The cochlear branch carries information regarding sound from the spiral ganglion of the organ of Corti within the cochlea. The vestibular branch carries information for the sense of equilibrium, both static and angular. The receptors lie in the vestibule and semicircular canals, which are fluid-filled chambers found within the temporal bone. The two branches combine at the internal acoustic meatus, forming the vestibulocochlear nerve, which enters the brainstem at the pons medulla junction. Cranial nerve 8 carries sensory information only. Hearing information is carried to the medial geniculate of the thalamus, and information regarding balance is carried to the cerebellum for processing. Cranial nerve 9 is called the glossopharyngeal because it serves structures associated mainly with the tongue, glosso and pharynx. It is a mixed nerve that emerges from the medulla oblongata and leaves the skull via the jugular foramen to reach the region around the throat. It is motor to the tongue. The pharyngeal branches are motor to the stylopharyngeus muscle, which raises the pharynx when swallowing. In addition to touch and pressure, the lingual branch of the glossopharyngeal nerve carries taste fibers from the posterior 1/3 of tongue. Other special sensory information is conveyed from chemoreceptors located in the carotid body at the bifurcation of the common carotid artery. These fibers monitor oxygen and carbon dioxide levels in the blood and thereby play a role in regulating respiratory rate and depth. Other sensory fibers carry information regarding blood pressure from baroreceptors located in the carotid sinus. Parasympathetic motor fibers from cell bodies residing. The otic ganglion innervate the parotid salivary gland, causing it to secrete watery saliva. When the mucosa on the side of the uvula is touched, the mucosa on each side of the uvula, not just the side that was touched, should rise. The amount of elevation of the mucosa on each side of the uvula should be equal. If there is damage to cranial nerves 9 and 10, the patient exhibits an abnormal gag reflex. In this picture, the left side of the patient's palate is touched with a tongue depressor. Notice that this results in an abnormal gag reflex in which the left side of the palate elevates more than the right side, and the uvula deviates to the left. This indicates to the examiner that there is a deficit to cranial nerves 9 and 10 on the right side. Cranial nerve X is called the vagus from vagrant or wanderer. It gets its name because it wanders throughout structures in the head and neck, thorax, and abdominopelvic cavity. It is the only cranial nerve that extends beyond the head and neck region. Its fibers emerge from the medulla oblongata and pass through the skull via the jugular foramen. Nearly all of the vagus nerve's fibers are parasympathetic, except those of the pharynx and larynx that are involved with swallowing. Thus, the vagus is involved with regulation of heart rate, breathing and digestive system activity. It also innervates the spleen and kidney. Sensory impulses come from the abdominopelvic viscera, and from the aortic arch baroreceptors, which sense blood pressure, and the carotid and aortic bodies, which are chemoreceptors involved with regulating respiratory rate. In addition, some taste fibers come from taste buds located in the very back of the tongue and superior pharynx. Cranial nerve 11 was formerly called the spinal accessory because it is unique in that it is formed from rootlets emerging from the cervical spinal cord. These rootlets from C1-C5 ascend superiorly along the spinal cord and enter the skull via the foramen magnum. The cranial part was thought to arise from the medulla oblongata, and it was believed that the spinal and cranial parts join to form a single nerve that exits the skull through the jugular foramen. This is currently being debated. Some neuroanatomists think that the cranial rootlets are actually from the vagus nerve. The nerve is mainly somatic motor to the sternocleidomastoid and trapezius muscles and therefore helps to control movements such as shrugging our shoulders and rotating our heads. The bottom picture shows an individual suffering with a lesion to his right accessory nerve. When the patient contracts the muscles of the neck, the left sternocleidomastoid muscle is easily seen but the right is absent. Looking at the back of the patient not shown here, the left trapezius muscle is defined and present but the right is atrophic and hard to identify. The hypoglossal nerve mainly serves the tongue. Fibers arise from roots emanating from the medulla oblongata. These fuse and the nerve exits the skull through the hypoglossal canal to travel to the tongue. The hypoglossal nerve innervates of the muscles of the tongue, which are important for food mixing and manipulation during chewing, and for swallowing and speech. It also lets us protrude and retract our tongues. Its sensory fibers are for proprioception position sense. Ever bite your tongue? To test the hypoglossal nerve, the patient is asked to stick out their tongue. Notice that in pictures on the right, the patient's tongue does not point straight out. In the top right picture, the tongue points to the left, and in the bottom picture it points to the right. The tongue of the patient in the bottom picture is flaccid, limp and fasciculated, wrinkled on the right side. It deviates to the right because of the weakness of the intrinsic muscles on the right side of the tongue. As a review, try matching the cranial nerve with its function.